Excellent. So good afternoon, everybody. Thank you very much for joining us this morning, this afternoon, or this evening. We are really excited for the lineup today for this webinar. The webinar today is on the provision of contraceptive methods during COVID-19 and considerations for differentiated service delivery. For those of you who have been with us on a previous webinar, this is number 6. So this is the 6th Tuesday you're sitting down with all of us, which is excellent. But we also want to welcome in our family planning and reproductive and maternal health colleagues that have joined us today. We're really excited to have you on with your technical skills and expertise. And I also just wanted to give a shout out at the top of the call to our Ministry of Health colleagues in Kenya for helping us connect to some new faces and some new voices. We're really excited. So as I've said a few times now, please feel free to go ahead and introduce yourself in the chat. You've all been muted when you entered the room, but we would also like to engage you in the Q&A. So if you have questions on any of the presentations or any of the content that comes up throughout the afternoon or the call today, please feel free to put it in the Q&A. This is a really important component of the webinar. So just flipping ahead, as I mentioned, this is the 6th in a series under the CQUIN Community of Practice around DSD webinar series that's being co-convened by ICAP at Columbia University, the International Treatment Preparedness Coalition, and the Differentiated Service Delivery Initiative of the International AIDS Society. My name's Dr. Anna Grimsrud, and I'm joining you from South Africa this afternoon, and I will be chairing the webinar today, but hopefully you will hear very little of my voice because we are very excited for the other people who've joined us as panelists. In case you've missed any of the webinars that have come before, we strongly encourage you to visit this URL on the CQUIN website, where you're able to access both recordings and the slides from the previous webinars. And we also hope and encourage you to block off this hour in your calendars for the remainder of at least the month of May. We have an exciting program that we'll be delivering to all of you. So in terms of housekeeping, I think I've covered this a lot, but don't fear, you have been muted, but you do have some power to raise your hand if you'd like to ask a question verbally, but we'd strongly encourage questions in the Q&A. As you'll see from the agenda today, we are gonna have a series of 4 presentations. The first will be from Dr. Kavita Nanda, the Director of Medical Research, who's joining us today from PLHIV 360 in the USA. And she's going to be sharing a presentation on contraception during COVID-19. We're then going to hear from some colleagues of mine, hopefully Dr. Maroney, if her web connection is strong, and or Dr. Bygrave, to talk about the intersection of family planning and DSD. Following that, we're excited that Stella Kantutsi, from the Executive Director of the National Association in Uganda, can join us and share with us some data around access to contraception among living with HIV during the COVID epidemic. And then last but certainly not least, we're going to hear from Dr. Kaliti, who's the Head of Reproductive and Maternal Health in the Ministry of Health in Kenya, who's going to give us a brief overview of the guidance that Kenya has put out regarding continuity of reproductive and maternal health and family planning during COVID. After that, we're going to try and have a bit of a panel discussion. This will be chaired, by my colleague, Dr. Bygrave, and we'll invite all the presenters to join this panel. And we're also really excited to have Ms. Rumbidzai Chidora from Zandiri Africade in Zimbabwe also join that panel discussion. So as mentioned, we'd like to ask your questions during that panel discussion. So please put questions for the panelists into the Q&A. And then finally, we will have a quick wrap up and answer any unanswered questions, hopefully in the final moments. So without further ado, I'm going to mute myself and hand over to Dr. Nanda to give the first presentation of the webinar. Thanks very much, everyone.
Thank you, Anna. Hi again, this is Kavita Nanda, and I am at PLHIV 360, where I work on family planning and work on developing new methods of contraception, as well as looking at the intersection between HIV and contraception. And I am really excited to be presenting to you today, and also even more excited to hear the other presenters. I don't know if any of you had the chance to look at the viewpoint, but some colleagues and I recently presented a viewpoint on some thoughts on what could be done to try and maintain high quality family planning services during COVID-19. And so my presentation is going to follow that viewpoint. Next slide, please. All of you know this, but I just thought it would be important to go over that family planning should be considered a priority in DSD and also during COVID-19. 50% of pregnancies are unintended. And as you all know, consequences range from unsafe abortion to serious pregnancy complications that lead to maternal morbidity and mortality. In this setting, contraception is life-saving and is an essential component of reproductive health care. And if you see from the graph on the right, as the use of modern contraceptives has increased, the number of unintended pregnancies has decreased. And so the family planning community has made remarkable strides all over the world over the past decades. And it's really important that as communities are threatened by COVID-19, that healthcare systems and providers consider family planning essential and continuity of reproductive health care in general essential to women and girls in the face of facility service interruption. Next slide, please. This was a recent analysis by UNFPA talking about the potential impacts of COVID-19 on family planning. And alarmingly, lockdown-related disruption over 6 months could leave 47 million women in low and middle income countries unable to use modern contraceptives. This could lead to a projected 7 million additional unintended pregnancies, along with their unintended consequences of maternal and neonatal morbidity and mortality. Next slide, please. So we at FHI had thought about, as this epidemic began, how health systems and providers could try to maintain high quality reproductive health services to women and girls. And some of this work was also based on some work I did for the American College of Obstetricians and Gynecologists, where I'm a member of their long-acting reversible contraceptive committee, where we had also come up with recommendations for the United States. Next slide, please. So one thing that could be really helpful, and I know that it's been discussed both for all types of care, including HIV care, but also for family planning, is use of telehealth. And telehealth does not necessarily have to be a video call. A lot of women and girls in many countries do have access to mobile phones, although they may not necessarily be the top of the line mobile phones. But telehealth could encompass SMS, using WhatsApp, video calls, or even telephone calls. And so what could this be used to do? Traditionally, when clients are seeking new contraception, they come in for face-to-face visits, but that doesn't necessarily have to be the case. Providers could use telehealth to counsel new clients, to check for medical eligibility, and then also to issue new prescriptions after assessing eligibility. This could be used for short-acting methods such as combined or progestin-only oral contraceptives, for combination patches, for vaginal rings, if no contraindications are evident. To minimize the risk of contact and to continue with social distancing, the prescriptions could be sent directly to the pharmacy or the clinic, and multi-month refills, as I know you've discussed for HIV treatment, should also be prescribed for contraceptives. In order to use telehealth, the health system and policymakers need to be supportive of this approach. For example, in the US, although telehealth existed until the Center for Medicaid and Medicare Services loosened restrictions on what it could be used for, it wasn't really used. But during the pandemic, many providers have been using telehealth to counsel new clients to provide contraception. Next slide, please. So what else could telehealth be used for? Many women using contraceptives have side effects, and often providers, we bring these women in to discuss the side effects, to provide treatment or management. However, once again, that doesn't necessarily have to be face-to-face. A lot of side effects and even providing treatment could be assessed over the phone or using WhatsApp or SMS, including for those women using LARCs, long-acting reversible contraceptives. Another thing that's really important to mention is that there will be commodity shortages for short-acting methods, for pills, for injectables, even for condoms. So it would be important to counsel women, even women using hormonal contraceptives, on fertility awareness, and also on consistent condom use in case of commodity supply disruptions. Next slide, please. Additionally, for those women who do desire LARC method insertion, telehealth could be used to screen them for eligibility, as well as to inform them of available service locations, which, hopefully a few will exist, depending on the individual country scenario. But the other important thing that I really wanted to stress here is that telehealth can be used to counsel current LARC users who are approaching the end of their effectiveness periods of their methods on the effectiveness of extended use, and also on postponing routine removals. For example, copper IUDs are labeled for 10 years. However, the data support use for 12 years or even more with very high effectiveness. Similarly, for levonorgestrel IUDs, both Abibella and Mirena are effective for at least 6 years. Importantly, the current etonogestrel implants, Implanon, Nexplanon, Implanon, NXT, are labeled for 3 years. However, there are good data that show 0 pregnancies in years 4 and 5. And so women who are approaching the 3-year mark in the setting of COVID-19 should be informed that there is no rush to remove and that the method likely remains highly effective. One thing I did want to point out is that if these are women on antiretrovirals, these recommendations do not apply to women who are taking antiretrovirals that may cause enzyme induction and lower effectiveness, such as efavirenz. For levonorgestrel implants, Sudel and Levoplant, there aren't as good data beyond 5 years or 3 years for each of those methods respectively. However, there are no safety concerns with keeping the implant in and providing additional short-acting contraceptives. Next slide, please. Another thing that providers and policymakers should consider is how to promote self-care for family planning. And even in countries where self-injection of cyanopress or subcutaneous DMPA has not been widely used, this is a method that has been shown to be safe and has been shown, as this bottom graph shows, to lead to higher continuation rates than provider-administered DMPA. And so during the time of COVID-19, I know that many areas are challenged, and it's sometimes difficult to introduce new ways of doing things. However, this is another method or another option that could be offered to women who are currently using injectables and coming into the clinic to get their injectables. Next slide, please. LARC methods should continue to be promoted because once they're inserted, they're pretty much forgettable and repeat contact is not needed. All efforts should be made, however, to provide LARC methods safely. So to continue to offer insertion of LARC methods such as intrauterine devices and contraceptive implants, adequate safety preparations should be made to avoid having too many clients in the waiting area. For example, scheduling individual appointments, having clients wait outside, and or ensuring adequate social distancing. The contact with LARC users, as I mentioned earlier, should really be either for insertion or to limit contact to situations where removal cannot be delayed due to side effects that cannot be managed, or where management of side effects requires a physical or pelvic exam or some other tests. For example, if an IUD user is having pelvic pain, then, for example, a vaginal discharge, and there's some suspicion of pelvic inflammatory disease, then those are the users who should be brought in for a pelvic exam. Next slide, please. Some additional considerations. Consider placing clients who desire permanent contraception on wait lists and offering them short-acting bridge contraception where they can be screened over the phone for eligibility. And also consider providing advanced prescriptions for emergency contraception, both to increase awareness and to reduce barriers to access, and to prevent future commodities disruptions. Next slide, please. Another important group of contraceptive users and future contraceptive users to consider are postpartum women. Women should be provided, ideally, counseling on family planning antenatally. However, while they are in the hospital, it's important to provide counseling on contraception before hospital discharge. If LARC methods are available, such as postpartum insertion of implants or IUDs, then they should be given these methods before they leave the hospital, because access to postpartum visits is likely to be impacted by facility service disruptions. If women desire postpartum tubal ligations at the time of cesarean delivery or after vaginal delivery, and these services are available, then all efforts should be made to provide these before the woman leaves the hospital. Next slide, please. Additionally, women should be counseled on the correct and consistent use of lactational amenorrhea, especially if other methods will not be available. For non-breastfeeding women, however, if they desire DMPA, then this should be administered before they are discharged from the hospital. In addition, for those who desire to use cyanopress, and if this method is available, this should be prescribed in advance, and women should be instructed in its use in sufficient quantities so that they should not have to return for several months. Additionally, women can be provided other methods such as progestin-only pills or combined oral contraceptive pills if they are provided with method-specific instructions to delay use until they are medically eligible per WHO criteria for either non-breastfeeding or breastfeeding women. So if they're using LAM, they should be given instructions on when LAM would no longer be considered effective for them. Next slide, please. So in summary, as the world grapples with the COVID-19 pandemic, we must continue to ensure that all women, men, and adolescents can access safe and affordable contraceptives. This is a new reality, and we don't know how long this is going to last. Adjustments are inevitable. However, all efforts should be made to maintain quality services and access to family planning services. We don't want to lose all the gains that we've made over the past decades. Next slide. And I just wanted to thank my co-authors, Elena Levetkin, Irina Jakobsen, Marcus Steiner, and Lenita Dorflinger. Here's a link to our viewpoint manuscript that just goes over the points that I went over with you today. I wanted to thank the other methods of the ACOG LARC group, and also thank our funder, USAID, that provided us with the funds to do this work. And that's it. Thank you very much. I appreciate your listening to what I had to say.
Thank you very much, Dr. Nanda, for that really great overview. And I would strongly encourage those of you who haven't to be sure to read the viewpoints and circulate it among your colleagues. Also just wanted to say thanks and welcome to the DSD family. We're really excited to have you join the call today, Dr. Nanda. And thank you to those of you who've put questions into the Q&A section already, and panelists, please be sure to check that out and check out the answered ones as well in case you'd like to add any more details. Without further ado, I'm going to turn over to Dr. Moroney to talk a little bit more about the intersection of DSD and family planning during the COVID-19 pandemic. Thanks, Chelsea.
Thanks, Anna, and thanks, Kavita, for that excellent presentation. I'm Chelsea Moroney. I'm a family planning doctor and a women's health epidemiologist based in Botswana, working for IAS. And I'd just like to acknowledge my co-author in this presentation, Dr. Helen Bygrave, who's also on the call today. The importance of access to contraception for women and adolescent girls is well established, and an integrated approach to HIV and sexual and reproductive health care has long been promoted as the cornerstone of the HIV response and recommended by bodies such as WHO. But progress in really effectively joining and delivering HIV and family planning care has been insufficient. One indicator that it underscores some lack of success in this regard is the measure of unmet need for family planning. Next slide, please. So what is the current situation globally? There is progress being made, with 53 million more women accessing modern methods of contraception since 2012. And prevalence rates increasing in the Africa region. However, approximately 225 million women still have an unmet need, and unmet need among women and adolescent girls living with HIV remains high, with over half of the 1.5 million annual pregnancies in this group unintended. Next slide, please. Recent published data from across the Africa region illustrate that there remains significant gaps, and highest unmet need is often among the most vulnerable. For example, adolescent girls and young women, women and girls postpartum, and key populations. Next slide, please. To bring this back to the CQUIN network, we at IAS have started to map out contraceptive unmet need, the method mix, and review HIV and family planning policies and guidelines across countries to begin to identify gaps and, more importantly, opportunities. This is still very much a work in progress, and this is just a sampling of countries and some of the data that we're compiling shown here. What we see is that between 1/4 to 1/3 of all women have an unmet need for family planning in these settings. And it's also important to note that need met does not necessarily equate to quality family planning care being implemented. High quality, effective family planning care is not simply about getting someone onto a method, but about ensuring that it's the right method for the right girl or woman at the right time, with information and method provision that's delivered in an acceptable way and in a location that meets her needs and preferences. We generally see here that uptake of the LARC methods, the IUDs and the implants, is low, with the DMPA injectable being by far the most common family planning method used in these settings. The subcutaneous DMPA injectable, the self-injectable, is mostly available still only in pilot settings and is not yet widely available at scale, but this is something that we hope can change urgently. All of these countries offer a range of DSD models, but on review of the operational guidance, more clarity on how family planning is being given within these models would be valuable. Next slide, please. So what opportunities are there to strengthen family planning by looking through the lens of DSD? How should we be thinking about this? Firstly, we need to engage people living with HIV, recipients of care, and how best to do this. We need to think about how can we use referral into DSD models and follow-up as opportunities for continuity of quality family planning care. How can we positively promote the long-acting reversible methods, the IUDs and the implants in these DSD models? If women in these models do not choose the LARC methods, because they are not the right methods for everyone, how can we align family planning and ART resupplies in the DSD models? For example, are we able to match ART and contraceptive pill refill durations to co-package? Can we match re-injection schedules to an ART refill schedule or expand where and how injections are given? And finally, how can we meaningfully and operationally integrate family planning and ART care in both DSD facility and community-based models? We're in a moment of renewed momentum around family planning and contraceptive care for people living with HIV. How can we capitalize on this to push for policy and implementation coordination, for collaborative planning, and for funding that enables real advances for family planning care? Next slide, please. Most of you on this call will be familiar with the building blocks. In the same way that we can use the building blocks to build a service delivery model for ART or for testing, we can also use them for thinking through how we might integrate family planning within our DSD models. So the when describes the time that family planning is offered and the frequency of interaction. The where describes what level of facility or how in the community it is delivered. The who describes the cadre who provides the family planning services. And the package of family planning commodities and services is described by the what. Next slide, please. This is an example from one implementing partner in Kenya. The women in the community ART groups in this model raised the point that they had to go to separate visits for their family planning care. Now the members of the CAG groups who need contraceptive re-injections or who need pill resupply are nominated as the ones to collect the ART for their groups every 3 months. 3 months of pills are given, and the timing of the 3-monthly injection is purposefully aligned to this schedule. Further adaptations are now being explored, which could potentially allow pre-packaging of pills so that this could be collected without each woman attending physically, and also the potential for community delivery of DMPA injectables or the expanded use of Cyanopress, the self-injectable. There's also recognition through this exercise that the vast majority of women here are using the shorter acting, potentially less effective methods, and that a focus on high quality counseling for LARC, as well as expanding the LARC options available, may improve the uptake of these methods. Next slide. IAS has been developing a short supplement on how D might be an opportunity to strengthen family planning provision for women living with HIV. Now faced with the COVID-19 epidemic, we believe that these principles may be even more relevant and that this is an opportunity to expedite this area of service delivery. We're interested in hearing from our partners about how we could utilize community-based ART distribution models for innovative delivery of family planning commodities. And with the ongoing COVID-19 response, we're going to have a unique opportunity to possibly expand what is distributed from community pickup points and through community models. So please do be in touch to share your experiences in this regard. We leave you with a few questions for further thought and discussion. Next slide. Thanks to Anna, Amira, and others who contributed to this presentation, and thanks to all of you for listening.
Excellent. Thanks so much, Chelsea, and really glad that your internet worked this afternoon so you were able to join us. And we're hoping we'll be able to get into some of those questions in the panel discussion. So I'd like to hand over now to Stella to talk to us about some recent data that has been collected in Uganda around access to contraceptive care among women living with HIV during COVID-19. So Stella, over to you. I'm hoping you can unmute yourself.
Thank you so much, Anna, and thank you for making this arrangement so that we share what we've been able to find out using the rapid assessment results NAFOPAN conducted with UNAIDS. So my name is Stella Kento, the Executive Director of the National Forum of People Living with HIV and AIDS Networks in Uganda, NAFOPAN. Next slide. Yeah, so as part of the background information, in Uganda, about 39% of women, including women living with HIV, use family planning methods, both short and long-term methods, but the majority of the women use pills. And with the COVID-19 lockdown, which our president extended by 2 more weeks as per last night, the lockdown has severely disrupted access to family planning. For instance, there are no public or private means for women to move to the facilities, designated facilities. And at the same time, because of the lockdown and limited transport, you'll also find few frontline healthcare workers at these designated at the facilities. The facilities are meant to be open, but then reaching these facilities is a big problem. And we also know that those who can access the nearby health facilities, they can actually move there. They're supposed to practice social distancing, but the majority of women actually are home waiting for lifting of the lockdown, because even what we call the nearby health facility is a number of kilometers away. And in the process, you are likely to have a post-COVID-19 baby boom, because those who require family planning methods are not accessing. We have also noted that there are challenges, especially the women negotiating abstinence, but also negotiating condom use for those who can access condoms when the spouses are mostly at home. So the challenge is that negotiation, and in the process, you're experiencing a number of increasing domestic violence cases, which the president also talked about, and we are calling for calm. We are hoping that in the process, as part of the proposals we'll give and also get from these presentations, that the women who are with their partners almost full-time can access these family planning methods. This applies to both women living with HIV and those affected by HIV. Next slide. And together with UNAIDS, we conducted a rapid assessment on the needs of people living with HIV. This was a quick one involving only 78 people living with HIV. It was conducted late March, early April. We are planning for an extended one, at least targeting about 1,000 people to give us better representation. But we are looking at the needs in terms of family planning, in terms of ART access, the duration that was there. And we note that most of the people had lesser than 1 month refill. And they were children, this silent population, they were children. And we are looking at how we can actually have these children targeted, but at the same time, the women who need these family planning services. Next. So when we asked about access to condoms and contraception, from the graph, you can see that 33% of those who wanted contraception had access, but then 57% of those who wanted the condoms had access. So when we look at the next slide, there is a disaggregation by men and women. So next slide. Next slide. So we had 78 respondents, so 61% wanted to use condoms. These 50% of these were females who wanted to use condoms as part of negotiation for safer sex, and only 16 respondents could access while the others could not access. When it came to men that wanted to use condoms, 19 had access and 11 did not have access to condoms at all. Out of the 78 respondents, 51 wanted to use contraception. Of these, 31 women living with HIV that wanted to use contraception, only 8 could access, and the 23 did not have access to the contraception. We also had men who indicated that they had wanted, 20 men had wanted to use contraception, but only 9 had access and 11 did not have access at all. So this becomes a huge unmet need of people living with HIV, especially women living with HIV, that we must be able to address as part of COVID and post-COVID cycle. Next slide. So what do we propose? Our key proposals include, we need to integrate the provision of family planning services in the delivery of HIV, TB, and opportunistic infection services. When we have these deliveries, especially in the homes, our IPs have been kind enough to deliver some of the ARVs and even TB drugs at home. So we propose that we need also to have the provision of family planning methods, where someone is using pills, then these pills also should be part of. But then how people will be able to know that there is need for family planning in a certain facility, we need to work with the expert clients and other peer buddies who are able to link up, who are able to call. We are trying to do social distancing and keeping away, but they can call, they know who requires family planning services so that these home deliveries can be made and people do not risk the unwanted pregnancies. We have a national task force, a district task force for COVID. We need also to prioritize. We've already written a letter to the Prime Minister, who is the overall chair of the COVID-19 response, so that the issues of sexual reproductive health, including provision of family planning, is provided during COVID. We are also proposing that we may need a specific study on access family planning services by women living with HIV, and not only on family planning, but how this is also impacting on elimination of mother-child transmission. Next slide. So this is our Ugandan National Referral Hospital, where we are discharging patients, and our core is as we discharge patients, we need also to provide the needed services for people living with HIV, including women living with HIV, beyond ART, to also cover the unmet need of family planning services. Thank you so much.
Thank you so much, Stella, for joining us, and really thank you to you and your UNAIDS colleagues for having the foresight to include questions around contraceptive care in your rapid survey. I know that others on the call may be involved in these surveys in their countries, and many of us are interested in hearing more. So we hope that you'll get in touch about what the data is telling you, and invite you to speak at future webinars, because this is highly relevant. All right, our last presenter for this afternoon is Dr. Kaliti, again from the Reproductive and Maternal Health Branch and the Ministry of Health in Kenya. And he's going to give us a brief overview of the guidance that they've issued around reproductive and family planning care and services during COVID-19. So without further ado, Dr. Kaliti, over to you. And just one quick reminder, please send your questions so that we can have a lively panel discussion following Dr. Kaliti's slides. Thanks very much.
Thank you, Anna. My preceding presenters, I think they touch a bit of that. I'll be speaking about the guidelines generally, but I know we are also having a focus on DSD and also family planning. So for now, what do I need to say? Welcome all for this presentation. Next slide, please. Let me be a little quick on this. What do we do? We came up with these guidelines after realizing that essential services are getting affected, and of course, reproductive maternal health usually bears the brunt during those times of crisis. So we quickly pulled out together, and the government led in this. So we came up with a guideline that we thought is likely to be comprehensive enough to capture all aspects of reproductive maternal health, including sexual and gender.
Sorry, just 1 second, Dr. Kaliti. Sorry, I think you've been accidentally muted. Sorry, carry on, we can hear you now.
Okay, thank you. So we said the guideline was sort of where is the lens of what needs to be done to get services back on track for reproductive and maternal health. And this came in after during the initial phases of the COVID-19 outbreak, just before we went to the phase of community transmission with a visit around the facilities, and it was the guidelines were informed by what the actually frontline caregivers were sort of experiencing also within the community, and some of that has already been mentioned by my preceding presenters. So it was basically a balance of trying to get what needs to be done vis-a-vis the risk of COVID-19 in the background. And what we did with a committee of experts, where they came together and the partners who participated in this, was basically to make sure that emergencies need to continue, but also in the background of those emergencies that must continue, to be able to scale down services that do not need, because we need to implement a new structure of how services will be given to be able to minimize the risk of COVID-19 transmission and infection within the facilities, and also make sure that care is given. Next slide, please. So like with any other emergency that comes in or during an assault, I'll call it an assault because we learned this a lot from physiology and the doctors can identify with that. When you are threatened, the response is usually very dramatic and swift. Number one, there's fright, there's flight, and then there's fight. And the same thing happened that we saw that within the health system. So the first fright was that everybody sort of saw that now we have COVID-19. We saw what was happening across the globe. And the first impulse was that we need to stay away from facilities. Why? We're running away because you need to be like safe, and facilities themselves were becoming like high risk areas or leaders of infection, and people did not want like to utilize those services. So that was the first thing we needed to take care of. After people were frightened, the response you saw in the initial phases, of course, was a little bit disorganized. because there are a lot of frenzy, and we needed to put people and pull people together to have to mount a jointed sort of a response. And then after the flight, and we saw that in the first few months, once the reality checked in, and we see that across the globe, and everybody see that now COVID is here with us to stay. We cannot run away forever. So we are putting up a fight, and the fight in quotes here is basically try to pull ourselves together and make sure we get normal services running like we're discussing today. So it is important what we learned from that. It's good to know where you are, because your response will be targeted onto that within the system. And especially for essential services, this is very real, because if you realize, like right now, the approaches you may use when the community has been pacified and is already knows that they need to go back to utilize your services may be a little different than the approach you'll use when people are already frightened and they're trying to shy away from the health system or from seeking care. COVID-19 outbreak, of course, challenged the traditional architecture of the way we provide service face-to-face primarily. And healthcare systems, of course, are designed on physical visits, which we are trying now to see how we can circumvent that. And of course, this brought in the guidelines have a major anchoring on telemedicine. And the telemedicine we are talking about here is not the, the top-notch kind of telemedicine we are talking about. We do have that framework, of course. We do have that service being established within the ministry across the country. But to get the services back, we are thinking about the common person, and we want to capture almost 100%. So if you say it's an approach that is sort of quite sensitive. We want to include everybody as much as possible and may not be very specific. And that's why it is just rudimentarily sort of telemedicine, where you can use the basic handset or basic phone, make sure you can call your local facility in a manner that is very easy for you at a no cost for yourself, be able to plan a visit within the facilities so that the facility can be given time to be able to manage the volume and at the same time redesign be able to reduce the risk of infection for COVID-19. So this is basically opening access in a sort of practical way, while at the same time making sure that we observe the containment measures for infection control for COVID-19. Next slide. So that said, let me focus on family planning and contraceptives because we do have the bigger picture where we need to get the bigger reproductive maternal health services coming back. Of course, labor has to continue. Utilization of services to go. There are issues of curfew and containment of, during restriction of movement. We need to get people to go through those barriers and be able to access services during an emergency. But for family planning specifically, we do have an array per method, and some of them have been mentioned by the first presenter. It is method specific, again, because each method at its own intricacies in manner of how it is delivered and the challenges that are there in the context of COVID-19. But the bottom line is that we needed to decongest facilities because one, it's a risk to the provider and also it's a risk to the seeker of the service or the client. And again, we anchored on telemedicine. Where possible, telemedicine will be employed to the extent, that is feasible. And telemedicine here also includes both scheduling the visits and making a call before you go for a service, but also using telemedicine to be able to source for availability of methods within you. And also we are having cases where telemedicine also working to be able to deliver methods and sort of perpetuate refills that do not need a lot of intensive consultation between the provider and the caregiver. Then there's also a deliberate shift to low interaction, low skill method mix. As you know, the method mix that has been shared is quite unique per country. But for us, of course, we have had a method mix that is dominated by interactive methods. Interactive methods are sort of provider, driven, because when you look like implants, you need a provider to be able to initiate that. You also need for injectables, and especially exemplary the Cyanapres, for the DMPA, the regular one, Depo-Provera, we also need to have injectable, and that is the provider with all that. So it brought in a lot of complexity because we need to make sure that women and users are maintained on methods, but at the same time make sure that we reduce the contact and that interaction until we figure out our health system how to be able to handle in the era of COVID-19. So based on the history and the review of the family planning method mix in Kenya, of course, most of you here in family planning, you are very much aware about the ECHO trial that just came in from WHO last year, and we discussed it at length. And one of the key things that were alarming, hormonal contraceptives per se do not cause HIV or STI, but the high incidence of STIs and HIV in the population that is using hormonal contraceptives, of course, was alarming, and it caused us to sort of redesign how we are doing it. And we are seeing the opportunity of anybody who is using hormonal contraceptives as an opportunity to be able to reinforce prevention methods. And we are actually emphasizing a lot on use of dual protection, and the condom here takes the, takes the baton in terms of being an accompaniment to the other methods, hormonal methods that we are using. That's why the dual protection here comes in. So as we protect against pregnancy, we are telling this useful population, do not forget about STIs and HIV. They're still real because we have a young population, as you know that. And with that useful population, the immediate concern may actually be pregnancy. And STI and HIV may be in the back of their mind. So these are method that needs to be reinforced. And we are seeing that the condom, we are packaging that to be able to make a major comeback in the discussion of couples and sexual partners, even when they are protected by other methods. And then, of course, we have seen a lot of challenges with the supply chain, and we are trying to make a deliberate effort for those in the family planning, discussions. You saw the disruptions that happened, of course, with some of the plans in India, and not only India, also across other countries that have been affected because plans have been relocated to be able to attend to COVID-19. We are aware of that, and one of the things that we did quickly, we are pushing for increasing months of stock within the facilities. Initially, months of stock, we are focusing on having 3 months, but we are pushing that to at least a minimum of 6 months to be able to help us rearrange and cushion ourselves, so that in case there's a disruption at the national level, at least at the facility level, we are sure that we are well stocked and we'll still be able to manage and handle. Next slide, please.
Apologies, Dr. Kaliti, just hoping to get you to move and finish up in the next minute or so we can have some discussion.
Yeah, please, next slide.
Thanks.
Yes, we are good. So what are the lessons that what have we seen there? There's a lot of scaremongering to public, and of course we need to move out with a lot of information to the public to know that essential services still need to continue, but in a safe manner. There's of course community attention, because we need to make sure that RH and FP and this is DSD is actually prioritized within this context, because everybody is angry for the cake in the phase of COVID-19. And we also need to have allocation of specific resources to be able to restructure the way services are delivered, not the traditional way we know. Talk about things like new approaches like telemedicine, they require resources to be put in there. And of course, we need to know how to handle panic response and be able to avoid, those kind of motivational prescriptions that are not backed by delivery actage. And we have seen a lot of those interventions there. The intention is very good, but you need to go a little bit more in the back room of the science behind the intervention that you're doing, and make sure that it makes sense that they'll be able to support prevention measures as well as continuity of care. Then, of course, as trained HR, we are talking about this, PP, material training, caregivers, being to give them emotional support. It's a major challenge, but we're handling that. Next, if there's any other slide there, maybe lessons learned. So what have we shared? Telemedicine and digital access care is not an alternative. It's actually become an integral part of healthcare delivery. And creative partnership are very essential. We have seen very, very noble solutions that are coming here from very untraditional kind of members that we did not expect. And vulnerable groups must be at the initial table of discussion during periods of violence inside of the systems. Like what happened with COVID-19, we have very essential services that were left out in the initial discussion. And it takes a long time to be able to bring it back to the table. So we need to deliberately be able, anytime we have challenges like this, be able to position the vulnerable groups right at the beginning of the discussion. We saw this with Ebola in Sierra Leone. It is coming back to haunt us with COVID-19. Women, and also a vulnerable group being left behind. Then it's very important to have central command. And here, I think the government has taken the lead in most nations, and Kenya is exceptional in that, taken a leadership to be able to minimize the damage and also sort of activate quick recovery measures, because the government is like everybody is looking for a leader during a time like this. So it's very good to have a very unified voice to be able to lead people through this. And then, of course, a very clear guidance is very, it sort of offers a lifeline. And I can say that, like in Kenya, the moment we went out with this guideline, we have seen a lot of progress, because in the counties, we're actually looking for what to do. And it has sort of created a nucleus of activity across the country. So it's important to get them quite early and out in an organized way. And of course, it's important to separate what are needs from wants and to be able to guide resource allocation. And I'm saying this deliberately because when you are faced with an emergency like we have right now, you need to filter what exactly is a need from what I want. And I'm saying that like when you go, for example, for methods, the method mix, in the basket, we want every method to be there, but some of them may not be possible at this particular time. So you need to be able to clarify to the client, it is okay for you to not to be able to have this at this particular time as we consult with you, but you can use this as a stop measure as we get our systems back on track. Thank you very much, Anna.
Thank you very much. So I'm going to now turn over to Helen to chair a brief discussion, and just recommend that for those of you panelists, as we are unlikely to get to everything within the hour, please do check out some of the Q&A questions and try and answer some of the open ones. Over to you, Helen.
Okay, thanks very much, Anna, and thanks for all the questions coming in. I think Dr. Kaliti has touched on some of these very real supply chain challenges, and really kind of, I think we need to dig into kind of the source. Is it that there is problems with commodities actually coming into the country because of supply problems at manufacturing level, or are there challenges due to the lockdowns in terms of in-country distribution? So we really recognise some of those supply chain challenges, which I'm sure many of us are facing. I just wanted to answer just briefly, a colleague asked a question about the community ART groups, really to bring this family planning and DSD conversation together. And in previous webinars, we've heard that a number of countries are looking at potentially scaling up community ART groups as a way of reducing interaction at the facility. And these are groups of between 4 and 10 recipients of care who meet at the community. Now, the adaptations that are being made is that community group meeting is not happening to observe the social distancing. But those groups are still acting as a means to distribute ART by nominating a member to collect the ART, and in the Kenyan case also for the women in the group, the family planning. But very important question raised is that this distribution is done observing social distancing. So a drop-off at another client's door. So there are adaptations that have been made to enable this community distribution of observing social distancing. And also, very good question, another question was around ensuring confidentiality. So this is obviously only done as well with the recipient of care's consent. I wanted now, if I could, which I think will encompass a number of the questions being asked, just to put a question to Rumbidzai Chidora, who is working for an organisation called AfricaAid in Zimbabwe that supports the care of adolescents and young people living with HIV. And Rumbi, I don't know if you could just share with us some of your experiences of the challenges of accessing contraceptive care for the members of AfricaAid and the young women needing contraceptive care since the lockdown in Zimbabwe, and to give us some of your perspectives of some of the challenges.
Okay, thank you very much, and good afternoon or good morning to everyone. So looking at the coming in of COVID into the world and Africa and Zimbabwe, I would like to say that there have been so many disruptions in what has been going on, and we have seen a lot of changes. And if you look at it, yes, we've been doing quite well ensuring that we have multi-month drug dispensation of ARVs to our young people, in trying to ensure that they are not affected or do not have enough medicine during the lockdown. But then, unfortunately, I can say that we cannot say the same thing for when it comes to family planning methods. And there's so much need to have the process of ensuring that young people do not miss any of the services they were getting before COVID, and there's need to coordinate and collaborate in this. So looking at it, yes, we have had in place initiatives to try and make sure that we have contraceptive care getting to the young people we are working with. If you look at it, we have been trying to make use of mobile health systems that we have in place. And we have been doing this through our peer supporters, the ones we are working with, the CATS, and some of the other countries we have been working with. We also have CATS and peer supporters. So what we have been doing is trying to ensure that we use these platforms to make sure that we share information and, when necessary, make possible referrals. But unfortunately, it is not every young person that we are working with access to mobile phones, let alone talk of smartphones that we can be using with them. So this has been a great challenge. And then if we are to look at it, when COVID came in, most priority has been placed on making sure that we are prepared well enough for issues to do with COVID. Thus, it somehow disrupted how other services were being provided for in health facilities. And it may not be the issue that the health facilities were not providing the services, but then the young people did not somehow understand the information that was given to them. So when the lockdown started in Zimbabwe, most young people thought that also the other services that they could get were also stopped, and some of them were not able to go and collect their contraceptive care from the health facilities. And also with the coming in of the lockdown, most public transport methods that the young people we work with were using were stopped, and we're only going to be authorized modes of transport to and from places that we want to go. And this was pretty much a challenge to the young people. Why? Because some of the modes of transport that had been authorized do not get to the places where the young people were working with stay. And some of them stay in very hard to reach areas, and they have to walk a very long distance to the health facility. And we're looking at a scenario whereby the community and the cultures we are coming in from, it is not much priority to have contraceptive care. And when we talk about it with maybe the cultural, looking at the cultural context, contraceptive care is not something that we can refer to or talk to when we're working with, is because the assumption is that you're a young person, what you're supposed to be doing is to abstain. So it has been also a challenge. And then we also have the issue of we're having authorities making sure that the movement is controlled within areas. So you would find that when young people would go to these checkpoints, they were asked to review what they are going to do. And some of the time, the young people were not comfortable in reviewing their agendas in the different spaces that they were working in. So it was pretty much of a challenge for them, because they were saying that these same authorities that we are going to be communicating with, where we are going and what we want to do at the health facility, they were actually people we know, and they're coming in from our facilities. So most young people would rather not continue with the journey because they cannot be disclosing what they're going to do at health facilities. And looking and where most of the young people are working with, and we're living in an economically strained situation. So you would find that young people, some of them, for them to survive, they're engaged in activities like sex work so that they get at least something to eat. So if we look at this issue, most young people who are selling sex, they going out to try and make a living for themselves, but then whilst at it and trying to get a living and earn a living for themselves, they are facing this challenge that most of the checkpoints that they go to, like the bars they used to collect maybe their condoms and everything, they have been shut down, and they no longer have that easy access to things like condoms. And it was pretty much difficult for them, which was actually a great challenge. So the fear now amongst us is that we are going to be having a lot of unintended pregnancies in the same group of young people that we are working with. And then we'd also want to look at
I'm just,
yes?
I mean, really, really interesting perspectives. I'm just a bit aware of the time and getting messages from Anna, and I just wanted to put one more question to Kavita, if I may. But Rumbi, thank you for sharing those experiences, because I think that those perspectives, particularly of young women and adolescents that are facing those challenges, are so important for us to remember. And for the organisation of many countries are running teen clubs, how is family planning really going to be continued in the light of the changes that might be being made to those teen clubs? So thank you so much for sharing your experience from Zimbabwe. Anna's allowing me just to slip one more question in, just to Kavita and maybe for Stephen to comment, because there's been a lot of questions. Kavita, your presentation focused on the use of telemedicine, and I just wondered with FHI whether you've started to actually get any on the ground kind of experience of how to do that and how successful that's been, and say maybe Stephen, you have some experience. And then just a specific question, if you know have any information regarding supply of cyanopress, and whether if there's an increased demand because of COVID to move to self-injectables, whether there's any thought globally to look at that supply in countries. So Kavita.
Yeah, so I'll answer your second question first, because I was just asking my colleague, Dr. Holly Burke, who's been involved in a lot of work on cyanopress, and she tells me that donors are working with countries on the supply of cyanopress. There also is work, although this will be, much later down, there's work on another version of a DMPA, subcutaneous injectable. So, but currently, she says that, donors are working to help ensure supply in different countries.
That's really good to hear. Excellent.
And then your second question, so right now within FHI, we, most of our work is providing technical assistance, although we do have a few programs where we directly work with those that are providing services. At this point, we are still in the information gathering phase. So we don't yet have experience with directly using telemedicine to provide contraceptive services.
Okay, thank you, Kavita. I don't know, Dr. Kaliti, on the use of telemedicine, whether you actually have any direct kind of implementation experience. I know it's a very, these changes have been made very recently, but if there's anything more you'd like to share on that to address some
Okay, thank you, Anna, for the opportunity. Do I have an experience? We are learning on the go. Again, this was an innovation that was made by necessity, because in the guidelines, one of the challenges that we faced as a government is that we are telling people to make sure they do not, congregate within facilities. We have healthcare workers who are stretched that we are trying to equip to the best level possible. And we have a system that is basically wired on face-to-face, which is actually a challenge during this time. And one of the guidelines was what we first said that please, as much as possible, try to make a call and get in contact with your facility or with your provider so that you can schedule either visit or you can explore getting your refills within that context. So the first thing that came in was, number one, we needed a platform where the normal patient can call back and seek information. And of course, we got the big telecoms on board, and we have a very active toll-free center that is, of course, being run and is able to give a question and answer and also be able to link, clients across board. So that was the first phase, and that worked in very well because as we spoke, within a space of 30, the tel, center, in a space of about a week, the call, volume went from a few thousands to tens of thousands. And even the chatty is actually in terms of hundreds of thousands. So the utility has picked up very well, which was good. So we went up with that. But a rider on that, you need to have a lot of commitment because of the cost, because this cost is being borne by the telecom, industry, and the government has to do a good partnering with them. And it was a good partnership in that manner. Now, then we came to the second phase. How about the ordinary person who actually would have utilized services? I have an implant, I need information. We have one call center that serves the entire country. It's overwhelmed with general questions on COVID-19, but now we need specific questions and guidance regarding to where we are. And this is why it was born. Each and every facility in Kenya, mobile penetrance is close to 100% for adult population. You're talking about upwards of 95%. And we basically observed that most of the facilities that we have, they do have a mobile phone. The only utility for this mobile phone is for communication within the facilities. Okay, the patient is not in the picture, or the community is not in the picture. So what we are doing is basically translating this platform into an organized platform that is standardized across all the facilities. And of course, we started with the government facilities that usually take care of almost 80 to 90% of the population when it comes to reproductive maternal health. And this population is the one we first focused on. And we're thinking like, if we can have an avenue where clients can get local information from their facilities, then we are good to go. And that's where also the telecom came in. And as we speak right now, the government is on top of it, and we have had a lot of partners, and maybe within the next 1 or 2 weeks, we hopefully will be going sort of live with it. But the entire concept is very simple. We have a standardized phone gadget across all the facilities, and these phones have unique numbers that are provided, of course, by the Telecom and the Communication Authority of Kenya. And these numbers are very easy to remember, so that if, for example, you are in Eswatini South and you see a short code toll-free number for your facility, you can tell you, if I'm in this zone, then I need to call 04122. Then it's very easy for the clients both to use and all that. And then we're covering the cost so that it is not coming at any cost to the client. And the discussion we're having now is how to pass that cost in the back room to be able to be spread so that it does not affect the user at all. And of course, I'll be coming back with Sherry how it is going to pick up. But so far, every indicator is that it's pretty well, because we are able to, reproductive health is a little bit tricky. You may feel you are okay, but it's an emergency, and it may not be understood as an emergency in the general parlance of medical, or medicine, and we know. And I'll give you an example. For example, somebody who needs an emergency pill, for example, somebody who is pregnant, has a little bit of a gush of water, she may be feeling well, but for a provider, we know that's an emergency, that it was necessary. So what we are doing is that the specialists within the counties, they're going to lead the clients through that screening, but also this service is actually linked to the emergency care, so that in case we have the people who hold the resources within the county at the local level, being able to be in the mix so that they can activate the system to be able to assist the woman or the client as quickly as possible. So that's basically a snippet, but of course I will be sharing a little bit more details as we go along, and that's basically what we have here as the first line in that approach. Thank you.
Dr. Thank you so much. I think that sounds really interesting, and I think my experience even here in the UK, it's learning on the go. I think that your engagement with the telecom companies is something for other program managers to really kind of look into, and I think we're surprising ourselves how mobile and agile we can be implementing some of these systems that actually might benefit our recipients of care, beyond COVID, we hope. So thank you for sharing that experience.
I just wanted to say, this is Kavita again, I just wanted to say something. So I learned something on this call, and I wanted to correct myself. Angela Akol, who is the head of our program in Zimbabwe, told on the chat box that the FHI 360 Zimbabwe program actually does have an FP call center that has been working as a telemedicine center.
Great. That's fantastic. Thank you, Kavita.
So all that's left is for me to send a huge thank you to Kavita, Chelsea, Helen, Stella, Steven, and Rumadzai. Clearly, as Helen said, this is a learning as you go sort of environment, but also you have all heard today about the passion and commitment from our various speakers, and you guys are displaying that by staying late on the webinar. As I've said in the chat, we're going to do our best to respond to the Q&A by asking the panelists to give us some answers, and we'll put those up alongside the webinar slides and the webinar recording, and we will hopefully see you all next Tuesday. Please also get in touch as you have examples and as if you have learnings, so that we can learn as we go together as a group. Thanks very much, and have a great day further.
Thank you, Anna, and bye.
Thanks, everybody.